Okay, so here we have another critical gestation preoperative aortic stenosis. You have been asked to review a 61-year-old gentleman in your pre-assessment clinic who is scheduled for a TURP next week. He had prostate trouble for over 5 years, past medical history, aortic wall replacement 2 years ago. Exercise tolerance is over 1 mile, lies flat without difficulty, drugs warfarin, bendoflumethiazide, bendro, flumethazide, doxazosin. These are the drugs he's taking. On examination, heart rate is 63, BP 125/85, normal heart sounds, chest clear, no ankle edema. Rectal reveals smooth enlarged prostate. So this is pathophysiology of aortic stenosis. What are the problems you might face? So patient has fixed cardiac output, limited coronary blood flow supply, cannot respond to decrease afterload, which may occur with anesthesia or blood loss. So when there is anesthesia, there is a dilatation of the blood vessels, so there is high compliance and low venous return and preload and so afterload. So such patients cannot respond to cannot increase their cardiac output. What is the pathophysiology of aortic stenosis? So aortic stenosis can occur in inflamed valves, either endocarditis or rheumatic disease. So in such cases, this gets stenosis. Sometimes congenital Ehlers-Danlos syndrome or also occur in those as well. So how to calculate coronary perfusion pressure? So coronary perfusion pressure, systemic diastolic arterial pressure minus left ventricular end diastolic pressure. Left ventricle end diastolic pressure. So this will be your coronary perfusion pressure. Left ventricular end diastolic pressure will be high in aortic stenosis due to left ventricular hypertrophy. So in aortic stenosis, coronary perfusion pressure will be decreased. So what happens that we have aortic stenosis, and so chronically the left ventricle get hypertrophied, so there is a small space, so the left ventricular end diastolic pressure will be high. So in aortic stenosis due to left ventricular hypertrophy, so in aortic stenosis coronary perfusion pressure will be decreased. Okay, so clinical picture of aortic stenosis is syncope, anginal pain, dyspnea, paroxysmal nocturnal dyspnea, orthopnea, pulses alternance, narrow pulse pressure, paradoxical splitting of S2, ejection systolic murmur, right second intercostal space on right sternal border. Asymptomatic in mild and moderate cases. If symptomatic, then it is severe and needs surgery. What is pulses alternance? Pulses alternance in arterial pulse with alternating strong and weak beats. Strong beat followed by weak beats. So what do you mean by paradoxical splitting of S2? So paradoxical splitting of S2 is the splitting of the second heart sound in during okay, so it is caused when the closure of the aortic wall. So basically you have the mitral wall and the tricuspid wall, so this closure causes S1 first heart sound, and the closure of the aortic wall and pulmonary wall, they will cause a S2 second heart sound. So what happens actually that we have the splitting means that it is caused when the closure of the aortic wall and the closure of the pulmonary wall are not synchronized during inspiration. Due to increased venous return, P2 is closed later. In a healthy person, A2 is followed by P2. So what happens that S2 is composed of two sounds. This is called splitting. So actually we have first A2, then followed by P2. So this normally occurs in inspiration, and while in expiration, normal patients normally these two are like very close together, and sometimes they are heard as one sound or sometimes heard as very little split. So in expiration this will be like this, and in inspiration this will be like A2 first and P2 later, like you will properly feel the gap. So this is normal splitting. And there is another thing which is called paradoxical splitting. So paradoxical splitting is the reverse of normal physiology. Splitting of second hot sounds during expiration, singular during inspiration. So normally, as we said, that during inspiration the splitting of sound is very prominent, very obvious. First occur the A2 and then followed by P2, but in expiration they are very close to each other or sometimes heard as one sound. But when in expiration when in expiration A2 is heard first, and with a gap and P2, so this gets prominent. First A2 will be heard and then P2 will be heard, and in inspiration they are very close, A2 P2, like the thing is reversed. So when this is reversed, this is called paradoxical splitting. So reverse of normal physiology, splitting of second hot sounds during expiration, and very close or singular during inspiration, this is called paradoxical splitting. And there is another thing which is called the fixed splitting. In fixed splitting we have both the same kind of sound, like A2 and P2, A2 and P2, same in expiration and same in inspiration. So when they are here the same in expiration and inspiration, this is called fixed splitting. Now there is a reason for this. So normally why this happens, so I will explain this at the end of the this tab, or okay, let's discuss it. So what happens actually, that we have in inspiration we have increased, here they have explained that in inspiration we have increased venous return, so P2 is close later. What happens that in inspiration the lungs or the chest cavity expand, so the venous return increases, blood flows into the venous, sorry, into the chest cavity, so this will comes into the right atrium. So when the veto or the venous return or the prelude is high, so they will fill the whole of the atrium and the atria and the ventricle, and they will take longer time to empty. They will take longer time to empty the right ventricle or the right atrium. So that is why the second heart sound is delayed because of this during inspiration. What happens in reverse or paradoxical splitting, that in and on the other hand in expiration we have the 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 pulmonary blood vessels, since in expiration the pulmonary or the chest cavity volume is decreased, so it is, so the blood is pumped into the atrium and the left atrium and the left ventricle. So what they happened, that in expiration they are the two sounds are come the two sounds come close together. And why the reverse physiology occurs, so the reason behind the reverse physiology, that we have the reversed splitting. Okay, so what is the cause of the reverse splitting, so or paradoxical splitting? So the reason or the cause of paradoxical splitting is the first, we have the aortic stenosis. The thing which we are studying is the first cause of the paradoxical splitting or no, reverse splitting. So so what happens that wait, so Okay, so we have, if the left ventricle emptying is delayed to the extent that the closure of the aortic wall occurs after the closure of the pulmonary wall, the effect of respiration on splitting S2 is reversed. It is more during expiration and less during inspiration. This is called reverse splitting. So what's the causes? So the cause of a paradoxical splitting or reverse splitting is left bundle branch block and hypertrophic obstructive cardiomyopathy and severe aortic stenosis. Okay, and the reason is that, okay, so normally the right sided cardiac output is increased during inspiration and left sided cardiac output is increasing during expiration, because the chest cavity is compressed during expiration, and so they push the blood into the right atrium and left ventricle, as I said earlier. So the two sounds, okay, so the right side, so the left side takes longer to empty the blood because the blood has been pooled there, and the left side has less blood during expiration, or the small input, or you can say preload, so they empty quickly. So these two sounds comes closer together during the you can say the expiration. And reverse splitting, as we said that reverse splitting, we have either the left bundle branch block or the hypertrophic obstructive cardiomyopathy, or we have the aortic stenosis. So in such cases we have the decreased reverse or paradoxical splitting. Why? Because suppose we have the aortic stenosis here. So the left ventricle, let's suppose this is stenosed, so the left ventricle will take longer time to empty into the aorta and the whole body. So and so as the left atrium as well. So if it is taking more time, so the P2 during expiration, the during expiration we have the sounds, the like the aortic sound A2 and P2 will they will be far apart, because this will sometimes this can occur earlier than A2 as well. So but usually they have A2 and then we have P2, and then during inspiration, since we have delayed P2 and the A2 is normally, so we have the P2 A2 near or close together, or like they are heard as one sound. So it's a bit confusing, but I will share the page. You can go through it as well, and the WhatsApp channel as well. So okay, so why syncopal attack occurs in this patient? So often occurs on exertion when systemic vasodilation occurs in presence of a fixed forward system. Okay, so the main problem in aortic stenosis is fixed cardiac output, so they cannot increase their output up to much extent. So when there is exertion or exercise, so there is systemic vasodilation in the body and the body demands increases. So sometimes because the cardiac output remains the same, so the systolic blood pressure declines or decreases, and this causes cerebral hypoperfusion and subsequently loss of consciousness. May also caused by the atrial or ventricular tachyarrhythmias as well. What are the causes of intraoperative death? So it can be due to myocardial infarction, because such patient cannot increase their cardiac output up to much extent, and there will be myocardial ischemia, or aortic dissection can also occur. How angina occurs in aortic stenosis? So this occurs in the absence of coronary artery disease. There is no primary issue in the coronary artery. So in aortic stenosis there is increased afterload, which causes left ventricular hypertrophy, because the left ventricle has to push against a resistance. Okay, so there is increased afterload which causes left ventricular hypertrophy. There is increased myocardial demand but decreased coronary blood flow. So when myocardial demand is more than its auto supply. Second reason is that the during diastole there is no much time, so the diastole is also weakened, During diastole there is less perfusion of the coronary arteries. How dyspnea occurs in aortic stenosis? So left ventricular heart hypertrophy and left ventricular failure causes backflow and pulmonary hypertension, which lead to pulmonary edema and dyspnea. There will be back pressure because this is your left atrium, this is your right ventricle enlarged, and this is your high afterload stenosis aortic valve. So they have to work hard, really hard, to push this blood into the aorta. So there will be back pressure always. So this can regurg, mitral regurg can occur, back pressure, and so the long-standing cases, the pulmonary hypertension occurs, and this will lead to pulmonary edema. What is the anesthetic consideration in this patient? As there is fixed cardiac output, patient cannot increase cardiac output when BP is low after induction. That may lead to MI due to reduced coronary perfusion, decreased coronary perfusion, and increased myocardial workload can lead to death. How will you calculate heart rate? So already we discussed this in another station, that if RR interval is equal, for example, the rhythm is normal, so 300 divided by number of large squares between 2R intervals. So we took 2R waves and calculate the count the number of large squares and divide 300 by this number. So you will, and if the heart rate is irregular, so number of QRS complexes in 30 large squares multiplied by 10, this will gives you the heart rate. Sorry. How will you calculate the excess deviation of ECG? So already we discussed in another station as well, that it will be positive in lead 1 and positive in lead 2, so there is no excess deviation. If so, for excess deviation always take lead 1 and lead 2. If there is positive deviation and here is also positive deviation, so there is no excess deviation. If here is positive deviation, here is negative deviation, so this is left excess deviation. You can see here that left excess deviation is positive in lead 1, negative in L2. So this is your left axis deviation, and right axis deviation is negative in L1. So if there is negative and here is positive, so this will be your right axis deviation, or it will, okay. So hypertrophy, so left axis deviation and S in a V1 the chest leads, plus or in V5 or V6, and if this combination gives you greater than 35 millimeter or greater than 35 millimeter, so this will give you left axis this hypertrophy, and so on the right axis deviation or in V1 greater than 7 mm. So it can give you the because of the hypertrophy there will be right axis deviation. And what are the complications of aortic stenosis? So left ventricular hypertrophy, hypertension, cardiac congestive heart failure, ventricular tachycardia, ventricular fibrillation, and angina. These can all be related to aortic stenosis. What investigation will you do for this patient? So as ECG is done already, I will do chest X-ray to and 2D echocardiography, transesophageal echocardiography, and coronary angiogram. What to do? Inform the consultant anesthetist, cancel the operation, call the operating theatre to cancel listing, explain the patient that this can alert him of the danger or counsel him about the complication which can happen in the operation. Discuss in MDT. If the patient had a bladder cancer, will you proceed to bladder surgery or valve surgery first? So this will depend on the severity of aortic stenosis. Normal aortic wall surface is 2.5 to 3.5 centimeter per square. If less than 1 centimeter square, severe aortic stenosis, so transvalvular gradient greater than 40 millimeter of Hg, so this is severe. So we will first manage aortic stenosis, and these are the gradings of aortic stenosis. So if the aortic jet velocity is less than or equal to 2, mean gradient less than 5, and 3 to 4 wall area. And so it goes for mild, and then we have the moderate 3 to 4, 25 to 40, 1 to 1.5, and then we have the severe greater than 4, greater than 40, and less than 1 valvular area. So this is your severe. Less than 4 aortic jet velocity meter per second, and we have the mean gradient greater than 40 millimeter of Hg, and less than 1 centimeter square area. So this is severe. If the operation was cancelled, what are you worried about? Spread of the cancer. Advantages and disadvantages of doing wall surgery first versus tumor surgery first. So wall surgery will increase patient survival, but at the expense of tumor spread. And if tumor spread surgery is done first, so it will but patient can die intraoperatively because of the complication of aortic stenosis. What is the current guidelines for prescribing antibiotic and aortic stenosis? So according to NICE guidelines, there is no need for antibiotic prophylaxis unless highly infected case. According to SIGN guidelines, no need for pre-operative antibiotics. What will you do? When will you do the operation? If severe aortic stenosis, if severe aortic stenosis so if we have severe aortic stenosis less than 1 centimeter square and greater than 4 aortic jet velocity, and then wall replacement, bladder surgery after 6 months. So first you have to do the wall replacement surgery, and then after 6 months you can do bladder surgery. If severe aortic stenosis with urgent operation, for example, if you have severe aortic stenosis and you have urgent surgery, another case like perforated viscous, so ballooning of aorta, and then proceed for operation. After 12 to 24 hours, I will go for definitive surgery for wall replacement or whatever for wall tackle. What is the non-surgical operation for the wall replacement? So TAV, or transcatheter aortic wall replacement. TAVR, transcatheter aortic wall replacement. So what is the aortic sclerosis? If it is an aortic wall disease without significant gradient, which may lead to aortic stenosis. Okay, so they can ask you what is the actual difference between the aortic stenosis and aortic sclerosis. So this, I leave this up to you. You find yourself the difference between aortic stenosis and aortic sclerosis. Okay, so we have the types of walls and the differences. So this also discussed in the patho station as well. So mechanical walls, long term 20 to 30 years, and tissue walls, short term 10 to 15 years. More risk of thromboembolism with mechanical walls, less risk of thromboembolism. Lifelong warfarin is required. Warfarin therapy is required for first 3 months. More noisy, less noisy, replacement is easier and comparatively difficult to replace. The tissue walls, with tissue wall there can be immunologic reactions. With mechanical wall there is less chance of immunological reactions. What is doxorubicin? So how does it work? So doxorubicin is alpha 1 blocker. This is alpha 1 blocker. So doxorubicin is an alpha 1 blocker which acts to relax the internal sphincter of the bladder and the smooth muscle of the prostate in order to reduce obstructive urinary symptoms secondary to BPH. So what is the result of stimulation of the muscarinic receptors found in the bladder? So they will cause retrosal contraction because the action of a parasympathetic nervous system and bladder. State 1 complication, that benzoflumethiazides. So benzoflumethiazide is a thiazide diuretic. This can cause that make results in surgery being delayed. So this can cause hypokalemia. It causes severe electrolyte imbalances. It can also cause hyponatremia as well. So you note that your patient is on warfarin. What is the mechanism of action of warfarin? So warfarin is an anticoagulant. It inhibits the action of vitamin K by inhibiting the vitamin K oxide reductase. So that is essential for the activation of 279 1972 to 10 9 and 7 and 2 clotting factors. How will you monitor warfarin therapy? By doing INR. What is INR? INR is international normalized ratio that can be detected by the patient PT divided by the normal control PT. Yes, so measure the extrinsic pathway and used in labs worldwide, and the normal is 1.1 to 1.22. 1.4 is normal. Yes, up to 1.5 is acceptable, and beyond this it will increase the chances of bleeding. And here I remember this by wept. The PT, the extrinsic pathway, and the warfarin.